Radiographic evaluation of normal canine and feline pulmonary parenchyma. The objectives of this video are to highlight key pulmonary structures visible on radiographs and develop an approach to evaluation of the pulmonary parenchyma on thoracic radiographs. This occurs by recognizing the normal margins of pulmonary parenchyma, understanding how to identify pulmonary infiltrates and how to recognize normal variants such as aging variants. A knowledge of normal pulmonary radiographic features allows us to differentiate abnormalities that may represent disease versus clinically insignificant variants. This in turn informs the decision-making process for your patients. Another objective of this video is to differentiate pulmonary arteries and veins and provide guidelines for assessing these vessels on thoracic radiographs. Recognition of pulmonary vessel abnormalities on thoracic radiographs can be key findings that strengthen your confidence in diagnosing certain diseases on thoracic radiographs. These principles will form the basis of your evaluation of the pulmonary parenchyma on thoracic radiographs. By recognizing radiographic abnormalities and through an understanding of disease processes, you will grow in confidence when drawing logical radiographic conclusions for your clinical patients. The pulmonary lobar margins, the opacity of the lungs, the definition and size of the pulmonary vessels, and the visualization of the bronchial walls should each be closely evaluated. Orthogonal radiographic views should be examined closely to help verify any abnormal findings and confirm that they are not artifacts or a clinically insignificant finding. Pulmonary lobar margins. In a normal patient, air-filled adjacent lobes and the thin pleural space make identification of the margins between lung lobes challenging. The diagrammatic overlays demonstrated in the right image are not clearly defined on the original radiograph shown on the left side. This is due to the lungs being air-filled, and therefore the same opacity to the adjacent lung lobes. This leads to border effacement and poor delineation of margins between two structures of the same opacity. Exceptions to this principle include the medial margins of the right and left cranial lobes, which are separated by the cranioventral mediastinal reflection, outlined by the blue highlight, and the lateral margin of the accessory lobe and the medial margin of the left caudal lobe, which may be outlined by the caudoventral mediastinal reflection, as denoted by the blue highlight. These mediastinal reflections on this image are outlined by blue arrows to allow you to examine these without superimposition of the blue shaded regions. The margins of the lungs occupy the majority of the thoracic cavity, being closely opposed to the thoracic wall. Cranially, the lung should extend at least to the level of the first ribs, as demonstrated by the white arrows. Caudally, the lungs overlay the diaphragm and cranial abdominal organs, such as the liver and possibly stomach, as demonstrated by the white arrows. Dorsally, there may be some superimposition with thoracic vertebrae, especially if there is rotation of the lateral radiograph. The dorsal pulmonary margins are demarcated in this radiograph by the white arrows. Ventrally, the lungs may extend to the sternobrae, as noted by the white arrows. In some individuals, such as barrel-chested, deep-chested breeds, or in cases of cardiomegaly, the pulmonary margins may terminate at the level of the mid to ventral cardiac silhouette despite the absence of pleural effusion. This is defined by the white arrows on the lateral image. This is differentiated from pleural effusion by identifying an absence of retraction of the pulmonary margins from the thoracic wall margins or pleural fissure lines on the ventrodorsal view and is considered a normal individual variant. As previously described, the pulmonary parenchyma is gas opaque due to gas filling of the alveolar spaces. In the region of the cardiac silhouette and superimposed over the diaphragm, it is more difficult to define the opacity of the lung. Both the cardiac silhouette and diaphragm are homogeneously soft tissue opaque, as noted by the regions outlined by the orange line. Normal gas filling of the pulmonary parenchyma is determined by identification of the well-defined pulmonary vessels that are superimposed over these soft tissue structures. These remain well-defined due to the contrast between the gas-filled lungs which surround the soft tissue opaque pulmonary vessels within the pulmonary parenchyma, as noted by the white arrows. Contrast this with these radiographs in a 2-year-old male neutered Mexican hairless dog. These 3-view thoracic radiographs were performed when the patient presented with increased respiratory effort, pyrexia, and increased lung sounds on auscultation. Take a careful look at the region of the right middle lung lobe, best identified on both the left, lateral, and ventrodorsal views. In this zoomed-up image of the left lateral view, partially superimposed over the cardiac silhouette outlined by the orange oval, there is a focal region within the right middle lung lobe where the lung is focally increased in opacity with poor definition, or border effacement of the pulmonary vessels by the surrounding soft tissue opaque lung. You can still identify normal pulmonary vessel definition within the surrounding, unaffected lung, as outlined by the white arrows. Additionally, note the thin gas-filled linear branching bronchi, outlined by the orange arrows, which contrast against the surrounding soft tissue opaque lung, also known as air bronchograms. This represents bronchi that remain at least partially gas, filled within a segment of lung where the alveoli are either collapsed or filled with fluid or cells. As with any radiographic finding, try to verify this finding through examination of the orthogonal view. In this case, on the ventrodorsal view, you can identify this increased opacity in the region of the right middle lung lobe with focal border effacement of the pulmonary vasculature outlined by the orange arrows. Assessing the bronchi. Bronchi are located between lobar pulmonary arteries and veins, and in healthy animals, the bronchial walls are thin, with the majority not readily identified on thoracic radiographs in normal patients. The radiolucent region between the pulmonary vessels, as denoted by the yellow outlines, define the regions where we should evaluate the bronchi. Occasionally, we can see the bronchial walls, most commonly in the proximal primary bronchi, where these walls may be thicker as noted by the white arrows, and therefore radiographically identified. Bronchial walls are progressively thinner towards the periphery of the lungs. Therefore, normal bronchial walls should be indistinct in the periphery of the lungs. Some peripheral bronchial walls are occasionally identified due to tangential imaging or thickening due to current or previous disease as noted by these white arrows. Tangential imaging may occur when the X-rays are more attenuated by bronchial walls due to the angle at which it hits the bronchial walls, such as with end-on bronchi. This does not tend to be a predominant feature of the lungs of normal patients, especially in the periphery of the lungs as denoted by the white ovals. Bronchial walls may be more easily visualized in small animals when pathology causes thickening or mineralization of the bronchial walls, or peribronchial cellular or fluid infiltrates. This typically presents as thin soft tissue opacities lining the gas-filled bronchial lumen, similar to tram tracks or donuts, known as a bronchial pattern. This is demonstrated in this patient by the white arrowheads on the right image. It is important to differentiate this from normal pulmonary vessels that are located adjacent to the bronchus. Identification of a bronchial pattern, especially when moderate or marked in severity, in the periphery of the lungs is an indicator of disease. Additionally, note how there is an absence of normal tapering in size within some of the bronchi, which should be markedly reduced in diameter towards the periphery of the lungs. The orange arrowheads demonstrate how these bronchi do not taper normally, consistent with cylindrical bronchiectasis, which can be identified with chronic bronchitis. Another circumstance where the bronchi are more easily visualized include when they are surrounded by fluid or cells, such as with the previous case of aspiration pneumonia, where there were well-defined air bronchograms. In this prior case, the walls of the bronchi are still normal, and the gas-filled bronchial lumen is defined because they contrast with the surrounding soft tissue opaque lung. In aged animals and with increasing quality of our radiographic systems, benign age-associated findings include mild increased opacity of bronchial walls, noted by the white arrowheads, discrete mineral opaque pulmonary nodules, demarcated by the yellow arrowheads, which are most consistent with benign pulmonary osteomas, and occasionally pleural thickening or mineralization of the costal cartilage, as noted by the pink arrowheads. These are clinically insignificant findings and considered normal age-associated variant. Additional variants that should be differentiated from disease include superimposition of normal soft tissue structures, such as superimposition of nipples, noted by the turquoise arrow. These can be differentiated by identifying these are not superimposed over the lungs on other views, identifying a paired soft tissue nodule or opacity, as noted by the two turquoise arrows, and by pasting barium paste on the nipple and repeating the radiograph. Pulmonary vessels. Well-aerated lungs allow clear visualization of lobar pulmonary arteries and veins. If lungs are consolidated or collapsed, vessels may become indistinct. When evaluating pulmonary vessels, the arteries are located dorsal and lateral to veins, and veins lie ventral and medial to arteries. This is demonstrated on the lateral and dorsoventral views, where the arteries are highlighted in red and the veins are highlighted in blue. Both pulmonary veins and arteries should be similar in size, as noted by the red and blue shaded vessels. Mismatch in size of the pulmonary artery and vein may be an indicator of pulmonary vascular enlargement. This is one of the most accurate methods of assessing pulmonary vessels, with the exception of cases in which there is concurrent, arterial, and venous distension. Objective evaluation of the pulmonary vessels can be performed by comparing the width of cranial lobar vessels with the width of the proximal fourth rib on the lateral views, as noted by the pink highlight on the lateral view. The width of the vessel is usually narrower than the proximal fourth rib. On the dorsoventral and ventrodorsal views, the caudal lobar vessel width should usually measure less than the width of the ninth rib, where they are superimposed with one another, as noted by the pink highlighted region superimposed over the caudal lobar arteries and veins. Strictly using these methods of objective evaluation of the pulmonary arterial and venous size will in some cases result in overcalling pulmonary vessel enlargement. Therefore, assessment should take into account the patient's clinical presentation, as well as other radiographic findings to help support your final radiographic conclusions. End-on vessels. Vessels aligned end-on with the X-ray beam appear as small, round, or oval soft tissue to mineral opacities. These are distinguished from true pulmonary nodules by consistent positioning adjacent or over vessels, smooth margins, oval, round shape, size comparable or smaller than adjacent vessels, and increased opacity compared to the adjacent vessel due to increased attenuation when in an end-on orientation. Note how the thickness of a side-on vessel in the diagram, measured by the pink line to the left of the image, is much smaller than that of an end-on vessel, as demonstrated by the orange line in the right of the diagram. This demonstrates why end-on vessels are more opaque than the adjacent side-on vessels. In summary, evaluation of the pulmonary parenchyma on thoracic radiographs for dogs and cats should involve careful scrutiny of the pulmonary margins, pulmonary opacity, which is aided by the visualization of pulmonary vessels over areas of the lung which are superimposed over soft tissue structures, and assessment of the bronchial walls. Recognition of normal variants is essential to differentiate true pathologic findings from clinically insignificant findings. Additionally, pulmonary arteries and veins should be carefully evaluated for changes in size, as these may be key findings that support certain diagnosis.